Hi everybody, and welcome to our module on the parathyroid glands. The parathyroid glands are four endocrine glands that are found in the neck located behind the thyroid gland as shown in this picture at the bottom of the screen. Embryologically, they are formed from the third and fourth pharyngeal pouches, and their job is to secrete parathyroid hormone, which is important for homeostasis of calcium and phosphate. Parathyroid hormone is a protein hormone. This means it is soluble in water and very different from the steroid hormones that are derived from cholesterol. Like most protein hormones, it binds to surface receptors that are largely found in the bones and also in the nephron of the kidney, as we will discuss in the next few slides. The cells that synthesize parathyroid hormone are called the chief cells, and they are found in the parathyroid gland. As I mentioned to you before, parathyroid hormone is important for maintaining levels of both calcium and phosphate. This means it has effects on both calcium and phosphate levels in the plasma. Its main effect is to raise the level of calcium in the plasma. However, it will also lower the level of phosphate in the plasma, and one of the ways in which it lowers the level of phosphate is to increase the amount of phosphate going out in the urine. So you should always remember these three effects as the major effects of parathyroid hormone. Now, some of these effects, as we will see, are due to a direct action of parathyroid hormone. Others of these effects are due to an indirect mechanism via activating vitamin D. There are several different triggers that can lead to the release of parathyroid hormone from the parathyroid glands. The major stimuli for secretion of parathyroid hormone is a low level of calcium in the plasma. This elicits the fastest response from the parathyroid gland. You can also see a rise in the level of parathyroid hormone in response to high plasma levels of phosphate and also to low levels of 1,25-hydroxyl vitamin D, which is the active form of vitamin D. The way that calcium manipulates the release of parathyroid hormone from the parathyroid gland is by binding to calcium-sensing receptors, or CASRs. When calcium binds to the calcium-sensing receptors, this leads to a drop in the amount of parathyroid hormone released by the glands. Magnesium can also affect the parathyroid glands, and it has a very similar effect on the glands to calcium. An easy way to remember this is to recall that magnesium and calcium are very close to one another on the periodic table of elements. Magnesium and calcium share many similar properties, and thus it makes sense that they should both exert a similar effect on the parathyroid gland. A high magnesium will result in a decrease in the amount of parathyroid hormone released by the glands. This is the same effect as calcium, and this is because magnesium can activate the calcium-sensing receptors just like calcium can. Conversely, a low magnesium level will lead to an increase in the amount of parathyroid hormone released by the glands. This is also the same effect as calcium, and this will lead to increased GI and renal magnesium absorption along with calcium, and this will help to maintain the calcium level in the plasma. There is one exception to the rule that magnesium has the same effect as calcium on the parathyroid glands, and that has to do with very low magnesium. If the level of magnesium gets very low, this will inhibit parathyroid hormone release. The reason for this is that some magnesium is required for normal functioning of the CASR. If the level of magnesium is very, very low, there will be abnormal function of the CASRs, and this will lead to a suppression of parathyroid hormone release. And the reason this is important clinically is that you can see hypocalcemia in the setting of severe hypomagnesemia, and that is from inhibition of parathyroid hormone release in the setting of very low magnesium. Another way to remember that calcium and magnesium can have similar effects on the parathyroid gland is to remember that they can both affect the QT interval on the surface EKG. If you look at this tracing on the top right side of the screen here, the QT interval is the interval from the beginning of the QRS complex to the end of the T wave, and it is normal in this example. Low magnesium and low calcium can both cause a prolonged QT interval as shown on this tracing on the left side of the screen. The QT interval begins here and ends about here. This is a QT interval of about 500 or more milliseconds, and that is very prolonged. Hypercalcemia, on the other hand, can cause a short QT syndrome as shown in this tracing on the bottom right side of the screen. Hypermagnesemia is not known to cause a short QT, only hypercalcemia. Now let's talk about the effects of parathyroid hormone on the different tissues and cells of the body. In the kidney, parathyroid hormone leads to increased calcium resorption in the distal convoluted tubule. I'll show you a picture of that in a minute. In the proximal tubule, you can see a decrease in the amount of phosphate reabsorption. We will also look at that in a second. And then also in the kidney, you can see an increased synthesis of 1,25-hydroxyl vitamin D, which is the active form of vitamin D. In the GI tract, parathyroid hormone leads to increased calcium and phosphate absorption. This is an indirect effect that occurs via vitamin D. And then finally, in bones, you can see increased calcium and phosphate reabsorption both directly through parathyroid hormone and indirectly via vitamin D. Now this may confuse you because some of these effects show a rise in the phosphate level in the serum, whereas the kidney will excrete more phosphate. You should always remember that the net effect of parathyroid hormone is to lower the amount of phosphate in the serum, even though it is increasing the absorption in the GI tract and the resorption in the bones. Here's a depiction of the effects of parathyroid hormone on the proximal tubule of the nephrons. Parathyroid hormone inhibits a sodium phosphate cotransporter found in the proximal tubule. This leads to more phosphate being trapped in the urine and thus being excreted with the urine. This will lead to a decrease in the phosphate level in the serum. Also in the proximal tubule, parathyroid hormone increases the conversion of vitamin D to its active form. There is an enzyme found in cells of the proximal tubule called 1-alpha hydroxylase. It converts 25-hydroxyl vitamin D into 1,25-hydroxyl vitamin D, which is the active form of vitamin D, and parathyroid hormone activates this enzyme. I talk about this whole process of activation of vitamin D in more detail in the biochemistry modules. One side note here is that this activation of vitamin D can occur independently of the kidney in diseases like sarcoidosis, and this is a way you get hypercalcemia in sarcoidosis. You have activation of vitamin D in absence of parathyroid hormone stimulation. Here's another depiction of parathyroid hormone effects on the kidney, this time showing the effects on the distal convoluted tubule. Parathyroid hormone can activate a pump that reabsorbs calcium in exchange for sodium. This will pull more calcium out of the urine and into the interstitium in blood and raise the amount of calcium found in the serum. Now I'm going to talk about the effects of parathyroid hormone on bones, and this can be a point of confusion for students because parathyroid hormone has multiple different effects on bone. It can stimulate both bone resorption and formation, and the dominant effect varies with the dosage and timing of administration of parathyroid hormone to cells in the bones. If you administer parathyroid hormone to bone cells and bone tissue continuously, you will see bone resorption and a rise in the serum calcium level. And this is the way the parathyroid hormone works physiologically, to raise the serum calcium level and keep it normal, or to raise it in the setting of hyperparathyroidism. If, however, you administer parathyroid hormone to bone tissue via a low-dose once-daily bolus, you will see increased bone mass and bone formation, and this is the mechanism of action behind the drug teriparatide. Teriparatide is an analog of parathyroid hormone, and it can be used to treat osteoporosis. This can seem counterintuitive. Why would you administer an analog of parathyroid hormone in a weak bone disease when parathyroid hormone causes resorption of bone? The reason teriparatide works is because when administered as a once-daily low-dose bolus, you see bone formation, and therefore it's beneficial in osteoporosis. To understand how parathyroid hormone works on bones, we need to review the types of cells found in bones. The first cell type are the osteoblasts. These are bone-forming cells, and they contain parathyroid hormone receptors, and they can increase bone mass in response to stimulation from parathyroid hormone. The other important cell type found in bones are the osteoclasts. These are bone-resorbing cells. They have no parathyroid hormone receptors, and they are activated indirectly by parathyroid hormone by way of the osteoblasts. When osteoblasts are stimulated by parathyroid hormone, they will synthesize a substance called MCSF. This stands for macrophage colony stimulating factor. It is secreted by the osteoblasts, and this will activate the osteoclasts. Also, when stimulated by parathyroid hormone, osteoblasts will synthesize a surface receptor called RANKL, which stands for receptor activating nuclear factor Kb ligand. This is expressed on the surface of osteoblasts, and osteoclasts have receptors for RANKL so that they can bind and become activated. So both MCSF and RANKL are produced by osteoblasts, and this is the mechanism by which they activate osteoclasts. And I've shown this at the bottom of the screen. The osteoblast makes MCSF. It also expresses RANKL on its surface. The MCSF can stimulate the osteoclast. The RANKL can bind to the osteoclast. And in this manner, the osteoclasts become activated, and they will reabsorb bone, and they will increase the amount of calcium and phosphate in the serum. A final detail about the mechanism by which parathyroid hormone affects the bones. Recall that there are two types of bone tissue. Cortical bone is the hard outer layer of bone, and this is the layer of bone that decreases in response to continuous parathyroid hormone administration. This is the layer that is reabsorbed so that calcium and phosphate levels rise in the serum. The other type of bone tissue is called trabecular bone. This is the spongy inner layer of bone, and this is the layer of bone which will increase in response to intermittent low-dose exposure to parathyroid hormone. There is another hormone produced by many cells in the body that is very similar to parathyroid hormone, and it is appropriately called parathyroid hormone-related protein. It's produced by many cells and tissues, and it's been shown to have numerous normal effects. What you need to know about this clinically is that it is synthesized in large amounts by some tumors, especially renal cell carcinoma and squamous cell lung cancer. This can lead to hypercalcemia in malignancy because parathyroid hormone-related protein exerts the same effects as parathyroid hormone, and thus it will raise the serum calcium level and cause hypercalcemia in malignancy. For the remainder of this module, I'm going to talk about disorders of the parathyroid glands, and we'll begin by talking about hyperparathyroidism, which is when the gland is overactive. And there are three forms of hyperparathyroidism. Primary hyperparathyroidism is when the gland itself is simply overactive. Secondary hyperparathyroidism is when the parathyroids are overactive due to persistent hypocalcemia. And then finally, tertiary is an unusual type of hyperparathyroidism seen in renal failure. Primary hyperparathyroidism is inappropriate secretion of parathyroid hormone, and the word inappropriate is very important. That means that the parathyroid gland is releasing parathyroid hormone not because of low calcium. This is commonly caused by a parathyroid adenoma, which is a portion of the gland that has begun functioning autonomously and is secreting parathyroid hormone on its own without being responsive to the level of calcium in the serum. The result of the excess secretion of parathyroid hormone will be hypercalcemia. You will see increased renal reabsorption of calcium, increased vitamin D activation, and you will see increased resorption of bone, that cortical portion of the bone we talked about before. You will also see more phosphate going out in the urine, and all of these are normal effects of parathyroid hormone. But in primary hyperparathyroidism, they are occurring not due to low calcium, they are occurring due to autonomous function of a portion of the parathyroid glands. And at the bottom of the screen, I've written what you see on serum testing in primary hyperparathyroidism. You see an increased level of parathyroid hormone and a high calcium, and this should never be the case under normal circumstances. Parathyroid hormone should only be elevated when the calcium level is low. However, in primary hyperparathyroidism, you have increased parathyroid hormone in the setting of high calcium. That is backwards, and that tells you something is abnormal. Let me make an important point about the urinary calcium level in primary hyperparathyroidism. The urinary calcium level is usually high or normal, and this can be confusing as a medical student. The high parathyroid hormone level leads to increased urinary reabsorption of calcium, and as you know, this is one of the mechanisms that leads to hypercalcemia. This can lead you to believe that the urinary calcium level should be low, but that is incorrect because there's another fact you need to appreciate. The hypercalcemia leads to more calcium being filtered, and this overwhelms the reabsorptive capacity of the nephron, and this leads to a rise in urinary calcium such that the urinary calcium level becomes normal or high. It is not low in primary hyperparathyroidism, and make sure you understand that mechanism. The symptoms of primary hyperparathyroidism are the symptoms of hypercalcemia, and those symptoms go by the mnemonic stones, bones, groans, and psychiatric overtones. Now, in reality, this is largely historical. Years ago, when there were no treatments for hyperparathyroidism, patients would have calcium levels that would climb and climb and climb until they developed all of these symptoms. In the modern era, most patients are diagnosed early in the course of their disease. In fact, most patients who are diagnosed are asymptomatic. Many primary care physicians check calcium levels annually on routine blood work, and they often make the diagnosis when the calcium level is elevated. Another common presentation in the modern era is recurrent kidney stones. Some forms of kidney stones contain calcium, and when you have mild hypercalcemia, one of the first things that can happen is you get kidney stones recurrently. The other signs and symptoms like stones, bones, groans, and overtones, when they are seen, are often seen in the setting of malignancy. Hypercalcemia malignancy can occur much more rapidly than hypercalcemia from primary hyperparathyroidism, and thus patients can quickly develop a high calcium level, and you will sometimes see all of these symptoms. So let's talk in more detail about the symptoms you can see in hypercalcemia and in primary hyperparathyroidism. As I said before, you can develop kidney stones. This is from high calcium in the urine causing kidney stones. You can also see dehydration in hypercalcemia. This occurs because calcium blunts the effects of antidiuretic hormone. This causes a picture that looks like nephrogenic diabetes insipidus with polyuria and polydipsia, and if it's severe, it can lead to renal failure. Bones refers to the bone pain that can occur in hyperparathyroidism. This is the result of the adverse effect on bones of long-standing high parathyroid hormone, and we'll talk more about that in a minute. Groans stands for abdominal pain. This is for the constipation, anorexia, and nausea that patients develop when they have high levels of calcium. In addition, it's long been known that you can see increased stomach acid production in patients with hypercalcemia and hyperparathyroidism. The mechanism of this is unclear, but you should be aware that recurrent peptic ulcers is also something you can see in hypercalcemia. And then finally, if your calcium level gets very high, you can become disoriented and confused. This is psychiatric overtones. Patients with hypercalcemia can have anxiety and altered mental status from the high calcium levels. Now I want to spend a minute talking about the bony changes that occur in hyperparathyroidism. Those changes are called osteitis fibrosis cystica. This is the classic bone disease seen in long-standing untreated hyperparathyroidism. The clinical features that develop and what the patient will complain about are bone pains and recurrent fractures. What's happening at the tissue level is that bone is being resorbed in the subperiosteum. You should remember this word subperiosteal. It's a USMLE buzzword. Recall that the periosteum is the membrane surrounding bone, and just below that layer, bone resorption occurs in hyperparathyroidism. This is commonly detected on x-rays in the bones, and in the fingers you will see irregular or indented edges to the bones, and that's because those edges just below the periosteum are being resorbed. The other classic finding of osteitis fibrosis cystica is called brown tumors. These are also sometimes called osteoclastomas. These are collections of giant osteoclasts in the bone. Remember that parathyroid hormone can stimulate osteoblasts and osteoclasts, so you can get giant osteoclasts in the bones that look like tumors on x-rays. The osteoclasts are mixed in with stromal cells and matrix proteins, and you get big black spaces in the middle of the bone seen on x-ray. These are two examples of what you could see on x-ray in osteitis fibrosis cystica. If you look at this picture on the left, you can see this black space in the bones of the legs. There's another one right here. These are those brown tumors. There's also a great example on the right in the hands. This is a brown tumor here. There's also one that you can see here as well. The treatment for primary hyperparathyroidism is a parathyroidectomy. This is a surgical removal of the gland that contains the adenoma. You can do preoperative nuclear imaging testing to identify which gland has the adenoma, and then that is the one that is removed at surgery. There are two risks of this surgery you should know about. The first one is there's a risk of recurrent laryngeal nerve damage. The recurrent laryngeal nerve runs in the neck close to the parathyroid glands, and if it becomes damaged, the patient may develop hoarseness postoperatively. The second risk is postoperative hypocalcemia. The remaining parathyroid glands may be suppressed. Remember, they have been underactive because the adenoma has been overactive. So when you remove the adenoma, it may take time for the remaining glands to wake up and start making parathyroid hormone, and in the process, the patient may develop temporary hypocalcemia, and this will present with numbness or tingling of the fingertips, toes, or hands. If it's severe, it can result in twitching or cramping. These are all signs of hypocalcemia. Secondary hyperparathyroidism is a disorder that classically occurs in renal failure patients. Renal failure patients have chronically low serum calcium. We'll talk about why in a minute, and this leads to chronic elevations of the parathyroid hormone level. This is actually a normal response of the parathyroid gland to low serum calcium levels. The problem is, if the parathyroid hormone level is chronically elevated, it can lead to bone damage. In this disorder, there are no symptoms of hypercalcemia because the calcium level is low. The problem is that long-standing elevations of parathyroid hormone lead to what's known as renal osteodystrophy. This is a bone disease. Patients complain of bone pain. That's the predominant symptom. They are also at risk for fractures. They have weak bones secondary to the high parathyroid hormone levels. And if it's severe and untreated, it can lead to osteitis fibrosis cystica, which has that collection of bone changes we talked about a few slides ago. And at the bottom of the screen, I've written the findings you will see on serum testing in secondary hyperparathyroidism. You will see high parathyroid hormone levels and low calcium. This is actually the normal response of the parathyroid gland. Like I said before, it's just a problem because this elevation of parathyroid hormone goes on unchecked for long periods of time. Tertiary hyperparathyroidism is also a consequence of chronic renal failure. Once again, that chronically low calcium in renal failure leads to a chronically high parathyroid hormone level. If this goes on for a long period of time, the parathyroid will become autonomous and it will release parathyroid hormone no matter what the serum calcium level is. This can lead to very high parathyroid hormone levels, and the calcium can become elevated in this case, and this often requires a parathyroidectomy to correct the problem. On this slide, I've shown the mechanism behind the chronically low calcium in patients who have renal failure. So patients with sick kidneys will have an elevated phosphate level because they cannot excrete the phosphate. In addition, they have low levels of the active form of vitamin D because the kidneys normally activate vitamin D. The high phosphate can bind with calcium and pull it from the plasma, and this will lower the serum calcium level. In addition, the low levels of vitamin D lead to less calcium being reabsorbed from the gut. So this all combines to cause hypocalcemia, which is what you see in renal failure, and this leads to hyperparathyroidism. In addition, you often classically see elevated phosphate levels in patients with renal failure, and they often take drugs called phosphate binders to lower the phosphate level. FHH is familial hypocalciuric hypercalcemia. This is a rare autosomal dominant disorder that tends to run in families, and it's caused by abnormal calcium sensing. There are abnormalities in this disorder of the calcium sensing receptors, or CASRs, that we talked about before in the parathyroid gland. These are G protein membrane receptors, and a number of abnormalities have been described in the different components of the receptor. And I talked before about how CASRs are found in the parathyroid gland, but you should also know that they are found in the kidneys and also many other tissues. So in this disorder, there is a higher than normal set point for calcium, so the patients can have a normal parathyroid hormone level, but the calcium level will be increased, hence the word hypercalcemia in the name of the disorder. In addition, because the CASRs are found in the kidneys, there is more renal resorption of calcium, and this leads to a low urinary calcium, hence the word hypocalciuric in the name of the disorder. The findings in this disorder are usually a normal parathyroid hormone level in the setting of a mildly elevated serum calcium. Then in the urine, you will see a low urinary calcium, and this is a very important finding. When you have hypercalcemia, you usually have a high urinary calcium because more calcium is being filtered and excreted. However, in this disorder, you have a low urinary calcium, and that helps to make the diagnosis. Now, in real life, this disorder can look just like primary hyperparathyroidism. Some patients have a mildly increased PTH level, and this can make it look like primary hyperparathyroidism. The real-world distinction from primary hyperparathyroidism, which is a much more common disorder, is difficult. There is genetic testing available, and it's important to distinguish this from primary hyperparathyroidism because FHH is usually mild and does not require any treatment, and you don't want to unnecessarily send a patient with FHH for a parathyroidectomy thinking they have primary hyperparathyroidism. Now let's talk about hypoparathyroidism. This is where you have an inappropriately low PTH secretion from the parathyroid gland. And once again, the word inappropriate is important. This means it is not due to hypercalcemia. And when you have hypoparathyroidism, you will develop hypocalcemia. And I've written the serum findings on the screen once again. In hypoparathyroidism, you have a low PTH level and a low calcium, and this is backwards. You should only have a low PTH level when the calcium is high. In this case, both the PTH and calcium level are low, and that's a tip-off that something is wrong. The signs and symptoms of hypoparathyroidism are the signs and symptoms of hypocalcemia, and those signs and symptoms are neuromuscular irritability and tetany, and let's talk about what those two terms mean. Neuromuscular irritability means abnormalities of the nerves and the muscles. In the nerves, the symptoms are tingling of the fingers and toes and classically around the mouth. In the muscles, the symptoms of hypocalcemia are intermittent spasms, and that's called tetany, and there are two classic signs of the tetany that occurs in hypocalcemia. The first one is called Trousseau's sign. This is where the hand spasms when you inflate the blood pressure cuff around the arm. The second sign is Schwastik's sign. This is contraction of the facial muscles when you tap on the facial nerve right next to the ear. And then finally, if the calcium level gets very low, you can develop seizures. The most common reason patients develop hypoparathyroidism is surgical excision of the parathyroid glands. This can occur on purpose after parathyroid surgery, but more often it is accidental after thyroid or neck surgery. And a classic scenario is a patient who presents a few days or weeks after thyroid or neck surgery and has tingling and spasms. That patient needs their calcium level checked. They likely have hypoparathyroidism. There are other much more rare causes of hypoparathyroidism. This can include systemic diseases like hemochromatosis with iron deposition or Wilson's disease with copper deposition, or rarely metastatic cancer has been described invading the parathyroid gland. All these things can destroy the parathyroid tissue and lead to hypoparathyroidism. There are two rare causes of hypoparathyroidism that you should know as a medical student for step 1. The first one is called autoimmune polyendocrine syndrome type 1. This is a rare autosomal recessive disorder that is caused by mutations in autoimmune regulator genes or AIR genes. Mutations of these genes are also associated with chronic mucocutaneous candidiasis, which is a disorder I discuss in more detail in the ID modules. Patients who have this disorder present with mucocutaneous candidiasis, which are candida fungal infections of the skin and mucosal membranes. They also develop autoimmune destruction of the parathyroid gland, so they have autoimmune hypoparathyroidism. And then finally, they develop Addison's disease, which is autoimmune destruction of the adrenal glands. This is very rare, and all you need to remember about this is that it's caused by the AIR gene, and it results in this triad, which includes hypoparathyroidism. The second rare cause of hypoparathyroidism is thymic aplasia or DeGeorge's syndrome. This is an immunodeficiency syndrome, which I talk about in more detail in the immunology modules. It results from failure of the third and fourth pharyngeal pouch to form. And remember, I told you before, the third and fourth pharyngeal pouches are the origin of the parathyroid glands. The classic triad of symptoms in this disorder is loss of the thymus, so there is loss of T cells and recurrent infections from immunodeficiency. There's also loss of the parathyroid glands, so hypocalcemia and tetany develops, and then finally, these patients also develop with congenital heart defects. So this presents in infancy or childhood with hypocalcemia from low parathyroid activity, recurrent infections, and congenital heart defects. The treatment for hypoparathyroidism is to supplement calcium and the active form of vitamin D, which is calcitriol. If patients take enough calcium and vitamin D, they will function normally despite not having an active parathyroid gland. There is a recombinant version of human parathyroid hormone that is available, but often it's not needed because if you supplement calcium and vitamin D, that's enough. The last disorder I'll discuss is a rare group of disorders known as pseudo-hypoparathyroidism. These are disorders where the kidneys and bones are unresponsive to parathyroid hormone. This is due to abnormalities of the parathyroid hormone receptor and its normal functioning. Many cases have been described due to impaired G protein signaling after parathyroid hormone binds to its receptor. These disorders usually present in childhood with hypocalcemia and hyperphosphatemia, and the parathyroid hormone level will be elevated. Now, this is an appropriate elevation to low calcium. Parathyroid hormone levels are rising, trying to correct the hypocalcemia, but they are unable to correct it because the kidneys are unresponsive and thus calcium is being lost in the urine. Therefore, in serum testing, what you see is a high parathyroid hormone level and a low serum calcium level. One of the forms of pseudohypoparathyroidism is called Albright's hereditary osteodystrophy. This is a rare autosomal dominant condition that leads to hypocalcemia, hyperphosphatemia, and elevated PTH by the mechanism we talked about in the last slide. It's also associated with a collection of typical clinical features that include short stature, shortened fingers, the fourth and fifth metacarpals are typically short, rounded faces, and mild mental retardation. All of the causes of pseudohypoparathyroidism are very rare. What they're going to want you to recognize for step one is that if you have a high PTH level, yet the calcium level is low, this means there must be calcium being lost somewhere. In other words, parathyroid hormone is unable to exert its effects on the kidneys and bones. And one of the mechanisms for that is a failure of the parathyroid hormone receptor in pseudohypoparathyroidism. So that's a nice segue into my final slide. Let me leave you with a couple of tips for how to approach problems involving serum calcium and parathyroid hormone levels. The first step is to look at the serum calcium level and decide whether it's low or high. The second step is to look at the PTH level and decide whether it is low or high. If they are both in the same direction, meaning both are increased or both are decreased, this means there's a problem with the parathyroid gland. If both the calcium and the PTH level are high, you have hyperparathyroidism. If both levels are low, you have hypoparathyroidism. If they are going in opposite directions, this is a normal response of the parathyroid glands to a calcium problem. The calcium problem could be renal failure. In renal failure, you have low serum calcium, and that causes secondary hyperparathyroidism. If you have renal losses of calcium and bones that aren't responding to parathyroid hormone, that could give you pseudohypoparathyroidism. But in all of these cases, you've got a normal response to some abnormally low level of calcium in the serum. And that concludes our module on the parathyroid glands.